Okay. So let me know when we start. So I'll do a brief introduction for you. And so you're, Nikolay, can you WhatsApp me 1 or 2 lines if you want anything to be, I just sent you a message.
Yeah, I see that. Well, you know me already, so you
Okay.
can.
So I'll introduce accordingly then.
Yeah.
Okay.
You just tell whatever you think about me. If you think bad, tell bad.
Okay, that sounds like a plan. So it looks like Khalid has joined also, right? You know, my screen is saying Khalid Mahmood. Is Khalid online or?
Yeah. Yeah, I'm online. Yeah.
Perfect.
Hi, hello, hi, Khalid.
Excellent.
Everybody has mask. Okay, that's a good thing. I will be without mask.
Same here. You know, I'm sitting alone, so you know, Khalid is wearing a mask, even though I know he's sitting alone also.
I'm at work actually. I'm at work.
So Salman, what time should we get started? Do we have? You want to give a few minutes, or should we get started? It's noon now.
Please start now.
Okay. So I have a distinct pleasure of introducing Dr. Nikolay Peev. He's basically in Belfast right now, and you know, I guess the front warrior in UK and US, you know, the West. But Nikolay, you know, I've known him for 2 years. Salman has known him for ages, but I would say as if I've known him for 2 decades. One of the finest people I've known in this coming back to Pakistan. He's based in Belfast, Ireland, and basically he's a complex spine, minimally invasive spine surgeon. And he will take us through spine localization, and mostly for the juniors, but I'm sure we'll all learn from him also, and then we can ask questions later.
Okay, right. Thank you so much for the kind words, and I'm gonna crack on now. It is again great pleasure to be with you. I miss you all, and I miss the conferences as we all miss them maybe. And this is alternative to meeting you in person, and I hope we'll try and we'll get the best of it. I'll try now to share my my screen, but maybe the host has to allow me that.
Emad is sorting that out for you now.
Okay.
Yes. Nikolay, go on, share, please.
Yes, I am desktop one. Let's see. Yeah, okay. Okay. Right. I'm not sure how should I do that. However, I'm having some technical issues here. I click share screen. Okay. Okay.
Yeah, and then click on what you want to share. It's coming up. Good. And then just play the good. Excellent.
Okay. Right.
Shahzad has joined us as well. Shahzad Shamim, welcome.
Hi, Shahzad.
He won't be able to hear you at the moment. He's muted. So.
All right. So I will continue. So again, this is a spinal lesion localization, back to basics. Hopefully will be good, and everybody of the auditorium will get something interesting. So before I start, I would like to remind you that sound knowledge of anatomy and physiology is vital when you assess your patients. And neurological diagnosis, when we talk about spine, is based on levels. And also, please don't forget to examine the last segments, as this is very important, and this will complete your examination. You can see on that slide there is a cross-section drawing of the spinal cord. you can discriminate here the gray matter, which is localized, which is organized as frontal horn, dorsal horn, both sides. And then, of course, we can see the white matter organized in tracts. So you can see that there is two main groups of tracts. There is motor or descending, so-called pathways, and we have also sensory or ascending pathways. The motor pathways are depicted in red, and the blue ones are the sensory or the ascending. The main motor pathway that we're going to discuss today is the pyramidal tract. And the main sensory pathway, of course, it will be the spinothalamic tract. Before I continue, I would like to remind you also that the fibers in the tracts, they are organized, they're not just scrambled, they are organized in a somatotopic organization. That means that, and as you can see also here, that the cervical fibers are medial if compared to thoracic, lumbar, and sacral. And that has clinical implications. This can explain conditions like central cord syndrome. This can explain conditions like somatotopic, like syringomyelitic dissociation of the sensitivity. This can explain the progression of the symptoms in a situation, in condition like in intramedullary tumor, for example. If you read the old books, the old clinicians will describe that as like progression of an ink spot. I don't know how many of you have seen ink spot though, but let's continue. So this is a diagram that is refreshing your memory about the main sensory pathways. Two main subsystems, the dorsal column system and the spinothalamic tract. As you hopefully remember, the spinothalamic tract is responsible for pain and temperature sensations, and the dorsal column system is responsible for fine touch and proprioception. These systems, both of them are three neuronal systems, but let's see what will be the difference. The pain and temperature tract starts with the first neuron localized in the dorsal root entry zone, and starts with the dorsal root ganglion and then goes through the dorsal root, and there it will meet the second neuron, which is located in the dorsal horn of the gray matter. And then what is important, and that has clinical implications, is that the second neuron will cross over, sometimes after traveling only a couple of segments upwards, and then will cross over on the contralateral side, and then it will meet the third neuron, which will shoot towards the postventral gyrus. This is the path of the pain and temperature. And the most important thing is that the pathway will cross over on the other side, roughly on the same segment where it enters the spinal cord, or the most 2-3 segments upwards after traveled upwards. Let's see now what's happening with the fine touch and proprioception. The fine touch and proprioception again starts in the dorsal root ganglion here, the first neuron, but then as entering the spinal cord, the neuron will start immediately traveling up. It will enter the dorsal column. That's why the system is called dorsal column system, and will travel up as high as the medulla, and then in the medulla will cross over, and then will go to the thalamus and then the postventral gyrus. So this, as I said, has clinical implications, and because of that, you can face a situation when you have one side missing pain and temperature, and on the other side, you can have missing fine touch and proprioception. But we will see later which conditions can give you that. So before I continue, also slightly refreshing your memory about the main descending, also called pyramidal tract, the motor pathway, which is of course responsible for voluntary movements. Unlike the sensory pathway, we have here two neuronal systems. The first neuron starts from the cortex, and then it will project its long axon that will travel through the internal capsule, then through the brainstem, and then just before entering the spinal cord will cross over at the level of the medulla and at the pyramidal decussation, and then it will travel down to reach the second neuron, which will be in the frontal horn of the gray matter. Then the second neuron will shoot towards the respective muscles. So two neuronal system, upper motor neuron and lower motor neuron, or you can say also central motor neuron and peripheral motor neuron, or first motor neuron and second motor neuron. These are three names for one and the same thing. And this is, you can see that in the literature, sometimes could be confusing, but you should know that this is one and the same thing. Three names, one and the same thing. A few words about this rubrospinal tract. The rubrospinal tract intimately follows the corticospinal tract, and its main role is suppressing the resting activity of the second motor neuron. Because of that rubrospinal tract and because of its suppressing role, the muscular tone is normal, as we know it with the normal patients. If the function of that rubrospinal tract is gone, the resting activity of the second neuron will be desuppressed, and you will see the spastic tone that you see in patients with upper motor neuron problems. Why it is happening? Because we said again that the rubrospinal tract is intimately following the first motor neuron of the motor pathway, and if you have injury of the first motor neuron, you normally will have also injury of the rubrospinal tract. So to recap, upper motor neuron or lower motor neuron problems will all give you reduced power. So everything will, if we're talking about motor neuron lesion, obviously it's going to be reduced power. But the clinical picture will be different if we discuss upper motor neuron problem or lower motor neuron problem. And the clinical picture becomes different when we add to that the muscular tone and also the reflexes. Let's see what's happening with the muscular tone if we discuss upper or lower motor neurons. So muscular tone, as we said, with upper motor neuron lesions or injury goes up. So you have increased or spastic muscular tone. And that's why when we discuss upper motor neuron paresis or paralysis, we call it spastic. Unlike that, with the lower motor neuron, we have decreased or missing muscular tone. And that's why the lower motor neuron problems are known to give flaccid paralysis or paresis. Let's see now what's happening with the reflexes. We have two main groups of reflexes. We have deep tendon reflexes, which are normal, but they could also become normal, abnormal, sorry. And we have also pathological reflexes, which are not present in the healthy patients, but you can see them in unhealthy patients. So deep tendon reflexes could be different and could change differently with upper and lower motor neuron problems. So with upper motor neuron problems, you have exaggerated reflexes, you can have polyclonal answers, you can have increased reflexogenic zone, and you can have clonosis. I will show you a few slides with that just in a second. Unlike the upper motor neuron lesions, the lower motor neuron lesions change the deep tendon reflexes with them going down, so they will be weak or missing. And finally, the pathological reflexes. With the upper motor neuron lesions, you can have present pathological reflexes and missing with the lower motor neuron. The most famous reflexes that you will use in your practice, Hoffman for the upper limbs and Babinski for the lower limbs. So to recap, apart from power, everything goes up with the upper motor neuron lesions. So if reflexes go up, spastic tone, and everything goes down with the lower motor neuron lesions, including power, including reflexes, including the muscular tone. So this is a good video showing how you can do the Hoffman reflex. Again, this was the pathological reflex that you examine upper limbs. This is very well defined Hoffman reflex, but unfortunately, in your clinical practice, not always this is not always the case. Say if you have to examine a patient with cervical myelopathy, which is where you most commonly will examine that reflex, you will not see this well defined in most of the cases, and you have to do it properly. The next slide is showing you reflexes of the lower limbs. You can see a normal Achilles reflex. Here you can see exaggerated Achilles reflex. Here you can see a polyclonal answer. You just see one tap and the patient reacts with polyclonal answer. Here you can see a clonus of the patella, and here you can see well-defined Babinski sign. So pathology of the spine falls in the following categories. It could be congenital, it could be developmental, it could be inflammatory, it could be degenerative, traumatic, neoplastic, metabolic. And again, the clinical picture depends on the level of the lesions. So if I have to talk about each of these separately, probably I will talk to you I will finish probably tomorrow morning or maybe even later. But obviously that's not possible. That's why I tried to group the lesions and to schematize the answer of the body and how the symptoms change in different situations according to the level of the lesion. So for didactic reasons, today I will give you the level of the lesion, and then I will give you the symptoms. But obviously in your clinical practice, it's the other way around. You see the symptoms, you combine them in syndromes, and then you think logically where would be the lesion. But if you can do from lesion to symptoms, then obviously you can reverse back and you can diagnose. So let's start with the first situation. So we are discussing now high cervical injury, which will be C1 to C4. Why high? Let's discuss why high. If you focus on that drawing now, you can see that that drawing obviously represents the spinal cord. The spinal cord is depicted with two enlargements. You can see here, this is a cervical, so-called cervical enlargement, and you can see here so-called lumbar enlargement. So the cervical enlargement is starting from segments C5 down to T1, and the lumbar enlargement starts from L1 down to S1. So why this is enlarged? We know from anatomy now that this is enlarged because this has the second neurons for your arms. So the cervical enlargement will have the second neurons for your arms, and the lumbar enlargement will have the second neurons for your legs. And why this is enlarged? Because we have a lot of second neurons here, which are necessary to control the so many muscles and to control them properly and to coordinate them. And then same thing for the lumbar enlargement. You have so many second neurons bodies that has to control your legs appropriately. And here the thoracic section obviously is thinner because you have the second neurons only for your intercostal muscles. There are not so many, and you don't need to be very precise controlling them. That's why not so many second neurons. So if we have obviously the first neuron traveling from somewhere from the brain here, it will travel, it has to travel all the way down to the cervical enlargement to meet the second neuron for your arms. But then the first neuron for your legs has to surpass the cervical enlargement and has to continue traveling to the lumbar enlargement to meet the second neuron for your legs. So this is what I find difficult for my juniors to understand, and that's why I'm stressing this to you. So let's see what happens now with high cervical injury. when the injury is above the cervical enlargement. Obviously, we will have lesion for didactic reasons here. In the next situations also, we will discuss complete injury, and later on we'll discuss also incomplete injury. But now just mind that we are talking about complete injury here. So complete injury, which is at the level of C1, C4 segments. Obviously, we will have lesion that will affect the first neuron for your legs and the first neuron for your arms, because the second neurons are in these enlargements. So that, of course, will give you central paralysis for your arms, and that will give you central type of paralysis for your legs. This is a paralysis, again, that will be with exaggerated reflexes, with pathological reflexes, with exaggerated muscular tone. And this will be a patient that will be spastic, will have spastic quadriplegia. Now, apart from the power in the clinical situation, of course, we have to examine other things. In this clinical situation, we have to examine also the sensory function. And your patient with high cervical injury will have a sensory level. The word that is very important here and that you have to say when you are discussing this with your colleagues is a level, sensory level. So the patient will have a sensory level that will correspond with the level of injury. As you can see here on the drawing, the patient is depicted as having sensory level that is just below the clavicle, and that corresponds with the C1, C4 lesion that is depicted on that diagram here. So just to remind you that this will, the sensory level will not be sharp line, but you will have a few segments that will be having some reduction of the sensitivity, but still there will be some sensation there. So, and the third main function that you will evaluate with these patients is the bowel and bladder function. Before I continue, I would like to remind you that the bowel and bladder function will follow the same rules as the rules for the central and peripheral type of paralysis. So again, this is a voluntary function, and the first neuron of the bowel and bladder function will start in area 4. If you remember the Brodmann fields, this is somewhere in at the middle, the median side of your hemispheres, and it will travel all the way down to the conus. So the second neuron for your bowel and bladder function will be located in the conus medullaris. So everything which is every lesion that is above the conus medullaris will give you central type disturbance for your bowel and bladder function. So what is central type bowel and bladder disturbance? This will be retention. So this patient will have retention of bowel and bladder. Usually this patient will be catheterized. Usually this patient will need, many of these patients will need manual desobstruction for the bowels. Otherwise they can go to ILS and they can die. This patient can die because of many reasons. Another problem that this patient have, another severe problem, is a breathing problem. So obviously, if you have cervical injury, you have lost your intercostal muscles, and these patients will have so-called abdominal breathing. The patient will breathe with the diaphragm. However, with the C1, C4 lesion, even the diaphragm innervation is impaired, because partially the diaphragm is innervated from the upper cervical segments, as you know from your anatomical knowledge. So this patient will have severe breathing problems. These are these patients that you can see in a wheelchair with support of a breathing, and that they are not possible to move anything. So let's continue further. Now we have the next scenario will be low cervical injury. Low cervical injury is the injury that is located at segment C5 down to T1. This is a bit inaccurate here, so it's going to be C5 down to T1. So C5 T1 injury, this is at the level of the cervical enlargement. And we said already that in the cervical enlargements, you have the second neuron for your arms. Hence, if you have injury here and respectively second neuron for your arms injured, you will have a patient that will have flaccid paralysis for the arms. So this patient will have flaccid paralysis for the upper limbs, unlike the lower limbs, where if you remember, the first neuron has to travel all the way down to the lumbar enlargement to meet the second neuron. So if you have injury at that level C5 T1, you have the second neuron for the arms, but you have still the first neuron for your legs. So like that, you will have a patient that will have flaccid paralysis for the arms, and you will have a patient that will have spastic paralysis for the legs. This will be different from the previous patient with the high cervical injury. This patient will not have problems with the breathing, but this patient will have same problems with the bowel and bladder function. It will be central type bowel and bladder function. This patient will go to retention for bowel and bladder. And the sensory level again will be corresponding with the level of the injury. The sensory level of that patient is a bit low comparing to the previous patient that I have showed you. Now, going down, we are now discussing a patient with thoracic injury. That will be segments T2 down to T12. So again, the cervical enlargement, again, the lumbar enlargement, you have a lesion that is located somewhere in the thoracic segments, which is below the cervical enlargement and above the lumbar enlargement. And this is what is important for you to think about. So what is the meaning of that? If you have obviously a lesion that is below the lumbar, the cervical enlargement, nothing is happening with the upper limbs. The upper limbs are working normally because the first neuron is intact, and obviously the second neuron will be intact. So you have a patient that has a lower limbs problem. The lower limbs are weak, but let's see what kind of weakness will be that. Because we are having lesion that is above the lumbar enlargement, obviously the second neuron for your legs will be intact, and hence you have spastic weakness for the lower limbs. You have spastic paraparesis or plegia. So this will be the patient that is in a wheelchair, and that is possible to ambulate with the wheelchair because the hands are intact, and he is possible to feed himself, he is possible to dress himself, but he's not possible to walk. Same thing is happening with the bowel and bladder, because the lesion is located above the conus. You have central type of impairment of the bowel and bladder function. Again, this will be retention of bowel and bladder. This is an interesting drawing that I would like to remind you in case you know it, and maybe to learn something new in case you don't know. This is so-called abdominal reflexes. Nowadays, we rely so much on the MRI scanners, CT scanners to diagnose our patients, but there is certainly situations where you will not be possible to access that, and especially in the nowadays crisis, that might be even more common. So with your clinical skills, you can well define where is the lesion alongside the spinal cord, and the abdominal reflexes can help you with that. Because the thoracic region is quite long, you have 12 segments. Based on the upper lower limbs and based on the clinical picture of the level, you can roughly say where is the level of the injury. However, the abdominal reflexes can reaffirm the diagnosis. What I mean with that, so you can examine the abdominal reflexes. There are 3 abdominal reflexes: upper, mid, and lower abdominal reflex. And the way how you examine is very easy. You scratch just under the last rib here for the upper one. You scratch towards the umbilicus for the mid one, and then you scratch towards the pubis for the lower one. And what you see if the reflex is happening is you see a twitch of the abdominal muscles. If you get the upper reflex, for example, you know that your upper cervical, upper 4 thoracic segments are working. If you don't get the mid reflex, you know that the mid 4 are not working. And if you get, for example, the lower one, of course, the lower 4 are working. So like that, you can discriminate upper, mid, or lower thoracic segments with these abdominal reflexes, and this is another confirmation of your diagnosis. Now, going further down, we are talking about a patient that has injury at the level of the lumbar enlargement. Obviously, the arms will be okay, the intercostal muscles will be okay, the patient is breathing normally. And however, this patient will have problems with the lower limbs. And again, because the second neuron will be impaired here, the lower limbs will give you a flaccid paralysis. So this is a patient that will have flaccid paralysis for the lower limbs, the upper limbs intact, and bowel and bladder again will follow the pattern of a central type of impairment. The patient again will be in retention for bowel and bladder. Again, the level will be corresponding, the sensory level will be corresponding with the level of the impaired segments. And finally, if you have injury of the conus or below, you will have coda equina compression type of symptoms. You will have different extent of bowel and bladder problems. You will have saddle anesthesia. You will have anesthesia for the legs. You can have also weakness. So this is very important for you to know. Coda equina syndrome, this, at least in UK, is one of the biggest reasons for litigation, and there is a lot of compensation paid each year for patients that have coda equina syndrome missed. So what is full coda equina, well-developed coda equina syndrome will be loss of anal tone, loss of perianal sensation, fecal and urinary incontinence, leg weakness, flaccid type paralysis, of course. And this is well-developed complete coda equina syndrome. This is a neurosurgical emergency, but if you get your patient in that final, well-developed, complete coda equina state, even if you operate, chances of recovery are not great. So you have to get your patient in the incomplete coda equina phase, where you can operate urgently and you can save functions. But this is another talk. This is another separate talk. So now let's complicate things a bit. So far we were discussing about complete injury of the spinal cord on different levels. Now let's complicate a bit and let's see what happens if there is incomplete lesion of the spinal cord. So this is a patient that has a lesion of the half of the spinal cord at level T11. Let's discuss what's happening with this patient and what symptoms you're expecting with half lesion of the spinal cord at T11 level. You can see that the left half of the spinal cord is impaired here, and let's discuss. Let's go logically how things will develop. So T11 lesion means that the patient has a lesion that is above the lumbar enlargement. Means that the first neuron for your legs will be affected, but the second neuron for your legs will not be affected. Hence, the patient will have spastic weakness of the leg. So this patient will have spastic paresis for the leg. And because only half of the spinal cord is affected, the patient will have only one leg affected either. So this will be left-sided monoparesis. This patient will have left-sided spastic monoparesis. And it will be left-sided because if you remember, the fibers of the corticospinal tract go on the same side on the inside the spinal cord. They don't cross. Let's see what's happening now with the sensation. The sensation is a bit different, and this will be the sensation will be different if you talk about the ipsilateral side of the lesion and if you talk about the contralateral side of the lesion. On the ipsilateral side of the lesion, the patient obviously will have missing joint position and fine touch. So it's going to be proprioception and fine touch missing on the same side. And on the contralateral side, the patient will have missing pain and temperature. Why is that? You can see on that diagram that this is reminding you, we discussed this in one of the first slides, that the fibers for the deep sensation, the proprioception, they enter the spinal cord and then immediately enter the dorsal column, and they travel on the same side. And this is why the patient will lose the deep sensation on the same side of the lesion. While the pain and temperature, they cross over. So that is why the patient will have pain and temperature problem on the contralateral side. This is so-called Brown-Séquard syndrome, as you know it. Now let's discuss another case scenario. This is anterior compression syndrome. You can see here the patient is having injury of the spinal cord at level T8 down to L5. Obviously, we have here the first neuron, but most importantly, we have the second motor neuron affected. You see the frontal horns are lesioned here. So the patient will lose the second neuron for the legs. And that automatically means that you can expect for that patient to have flaccid paralysis. So this patient will have flaccid lower paraplegia or paralysis. And this is a patient, again, that will have central type of impairment for bowel and bladder function. And the sensation will not be affected for that patient because the sensory pathways are intact. The spinothalamic tract will be intact, and the dorsal column will also be intact. So that's why the proprioception will be preserved. Posterior compression syndrome, similar way of thinking. We have a lesion here at T10, T12, mainly of the dorsal column. Hence, mainly the sensation for mainly the proprioception and fine touch will be affected for that patient. So, and finally, intramedullary lesion, same way of discussing and same way of developing of the symptoms. You have a lesion that is developing in the frontal horn at level C4T1. This is a lesion that will obviously impair the frontal horn, means the second neuron for your arms, because it's at the level of the cervical enlargement. Hence, this patient will be having upper limb flaccid paralysis. But because as you can see here, the corticospinal tract is also affected by the lesion, the patient will have lower limb spastic paralysis. So these are the intramedullary lesions that can give you problems. Now, before we continue, I would like to stress on the fact that, again, from my practice, when I work with the juniors, they have difficulties to understand. So at the end of that lecture, when I ask them, so you have now a patient that has L1 lesion, L1 vertebra lesion, let's say L1 fracture. what kind of symptoms you expect to have. And most of my juniors will answer at the end of that lecture. The patient will have lower limb spastic problem, but that's not the case. And why that is not the case? Because we have to be specific, and we have to bear in mind whether we are talking about spinal canal vertebra or we are talking about spinal cord segment. And if you remember from your anatomy, is that the elongation of the spinal cord during the development is slowing down, and it's delayed comparing to the elongation of the spinal canal. So in an adult individual, in an adult patient, the segments of the spinal cord are not corresponding to the segments of they are not corresponding to the vertebrae. So this is useful for me diagram when I diagnose to show how much of a delay of the spinal cord comparing to the spinal canal. So you can see here that at level of C4 vertebra, you have offset roughly of +1 segment. So you have C5 spinal cord segment. At C7, you have already 2 vertebrae offset. So you have already T1 spinal cord segment. At T6 is +3. At T12 will be +4. At level of L1, you have the whole, usually you have the conus medullaris, and at L1 and below, you have coda equina. So this is important for you also to think when you are diagnosing your patient. So if you have L1 fracture, you will not have spastic, but you will have flaccid problem for the lower limbs because this is conus medullaris, and this could be your lumbar intumescence as well here. Lumbar enlargement, sorry. So this is another another picture that I would like to discuss here today. Another problem that juniors are having difficulties to understand is the relations between the in the lumbar region, relations between the exiting and traversing nerve root and the relation of the level. So let's discuss here level L4, L5. For didactic reasons, we'll say that this is L4, L5. On the left-hand side, you have a spinal canal, spine completely preserved. On the right-hand side, you have unroofed. And you can see the exiting and the traversing nerve roots. You can see the disc here. So let's say this is L4, this is L5. At that level, we have exiting L4 nerve root, and we have traversing L5 nerve root, and this is the disc. So what I find difficult for my juniors to understand is why at level L4, L5, disc herniation, we have exiting L4, but most commonly you have L5 affected. So you at level L4, L5, if you have L4, L5 disc herniation, mostly your patients will come to you with L5 problem. And why is that? The answer is that the disc herniation normally will go in that area. About 80%, about 90% of the disc herniations will be in that area, and that will affect your traversing nerve root. And that is the reason why when you have L4, L5 disc, you have L5 instead of L4 problems. In a rare cases where you have bilateral discs, you may have L4 a problem with your patients. I have to remind you also that there is anatomical variations. On that slide, you can see a low starting nerve root. You can see high starting nerve root. You can see a double root here. Okay, I think we have to stop here, and we have to give maybe chance for questions. Someone or the moderator?
Brilliant talk. I think we have the two moderators. Can you hear me?
Yes.
Can we be unmuted, please?
Yes. So Shahzad and Asif, Shahzad, if you say something, you will be able to talk to us.
Shahzad, are you there? Let's see you. Yes, I can see you here now. So we'd like to welcome Shahzad, Dr. Shahzad Shameen from Aachen also. He's been here, but Shahzad, you want to start with the first question, please?
Yes, can I be unmuted? Oh, fine. Thank you very much, Nick. Thank you very much, Nick, for the wonderful talk. So thank you, Asif. Maybe I can start with the first question from the chat group. We have a question that, Nick, how do you explain the hand weakness in carry malformation? And how do you explain the neurological signs in syringomyelia?
Right. Okay. So Chiari, as we know, Chiari malformation. One of the most common problems with Chiari malformation is the formation of syrinx, and then the syrinx can give you different problems with your arms and with your legs, and also with the sensitivity. We know about the sorry, not sensitivity, but sensation. We know about the syringomyelictic dissociation of the sensation. And to explain the symptoms, you have to go back to the diagram that I showed to you for the sensory pathway, the two subsystems, the dorsal column and the spinothalamic tract. And you can see that you have to remember that the dorsal column system goes straight to the dorsal column. That's why it's a dorsal column. And the spinothalamic tract crosses over, and that can explain why your patients will have on one side missing deep sensation, and on the other side missing the pain and temperature. And also, obviously, when the cyst is growing, that is impairing the second neurons in the segments that it is located, and that can give you respectively symptoms for the arms, and then on a later stage, when the cyst becomes bigger, that can give you symptoms for the legs as well.
Good. So I'd like to read out the second question. How do you diagnose the level of injury in the thoracic lesion without sensory level? So I think he wants to find out, without doing a sensory examination, how can you do a level of injury? Is that the question?
Okay, well, I can, so obviously sensory, I don't know why would you diagnose without sensory level. Sensory level is very important for you to examine when you examine your patients. But before even you examine your sensory level, you can roughly say that this is a thoracic lesion. If you go and examine your patient, and if you see that this patient has normal arms, everything is working with the arms, and if you go and examine your legs and you see that there is a spastic problem there is a increased muscular tone, in case there is pathological reflexes for your lower limbs, in case you see retention of bowel and bladder, you obviously can say that this is a thoracic problem. However, if you go and examine your sensory level, that will further confirm the level. With the sensory level only, you can roughly say within 2-3 vertebrae where exactly will be the problem. So sensory level is important. Remember, I showed you these abdominal reflexes. With the abdominal reflexes, you can also discriminate which segments are roughly impaired in the thoracic region, because I told you that 12 segments, there are too many, and sometimes you have to be a bit more specific. So if you would like, based on a clinical examination, to diagnose, you have to get as many signs as possible, and you should not restrain yourself with one or the other. You have to get everything, and sensory level is very important for you to take. However, if for some reason you cannot take the sensory level, you still are possible to roughly diagnose based on the other signs and symptoms.
Yes.
Sorry, can I just interrupt here? I'd request all the participants to kindly fill a multiple choice question that is already posted on the chat. All you need to do is pick up the link and put it on your whichever server you're using. And you can see, you just need to fill your name, your email address. And the idea is that this is CME for 2 hours that's approved by the university. So what happens is you get a certificate by mail for attending this. And on top of it, we get a feedback on has Nick taught you in good way or not. And we also ask a question that, do you like the presentation and would you like to hear this person again? And so let's see how many people want to listen to Nikolay again.
Good.
So,
good.
so there's a feedback. So just if you guys could go, and there are 3 multiple choice questions in that. At the end of the session, we will go through those questions with Nikolay and see has he taught what you're supposed to teach. So let's see what we get. So now we go back to questions. Moderators, please. Sorry.
Great.
Okay,
So,
I'll
go ahead, Shazad.
please carry on. Okay, so I'll ask the next question. It's from Nurulhuda Maria, and she's asking how to interpret these findings and the exact level of pathology in a patient who already has polyneuropathy if we do not have the nerve EMGs and nerve conduction studies to correlate. So that's a tricky one.
Yeah, well, obviously, this is when you have many conditions on board. Of course, the situation is becoming more complicated. So we are talking today about, going back to the basics and knowing the clinical signs and symptoms, but we have to admit that we cannot go back to the dark ages. And that's why we have the modern investigations like EMG. That's why we have modern investigations like CT scanners, MRI scanners. So of course we have to consider that, and we have to get that on board when we can. And there will be conditions that will not be possible to be diagnosed based on only clinical examination. Clinical examination is important, and we have to know it. But I'm not an advocate that you have to forget about MRI scans, you have to forget about CT scanners, and you have to just go and diagnose all of your patients with the tendon hammer. That's not the case. I didn't mean that. If somebody understood that, please don't.
Great. So, by the way, Nikolay, how much you have more talk also to follow, right?
No, I think I'm done, and I think the time is also advancing. We are 8:54 now.
Perfect. So let's go through these. I'll forward you the next question from Dr. Ali Tasadduq. How to differentiate a lesion of the upper C-spine from lesion in the brain if the symptoms are unilateral and no symptoms other than weakness? So basically, patient presenting with motor weakness and unilateral.
Okay.
So how to differentiate between C-spine and the intracranial?
Right. So obviously you have a lesion in the brain that will give you weakness. And you have to see obviously the other signs and symptoms. So here it will be the, you have to see what kind of lesion is that. You have to see what kind of problem you have for the upper limbs. You have to see what kind of problems you have for the lower limbs. And you have to, obviously, if it's a brain lesion, that will be a spastic problem for the upper and lower limbs. Also, if you have a brain lesion, there is a chance that you have cranial nerves involved, not only the spinal nerves. So that is the importance of you having to do the full neurological examination of your patients. It's not only if you're a spinal surgeon, you go and examine only the limbs and that's it. You have to still know the cranial nerves. You have to do full neurological examination. That is the importance of also the sensory levels. So this is how it goes. So you go and examine the patient fully, and then for sure you will have clue that this is a brain lesion. You will have you can have signs of intracranial pressure. You can have signs from the ophthalmoscopy. So you have to do a full examination, and that's it. And this is a very good question, and thank you so much for that. This is to to stress the importance of the proper and complete neurological examination of your patient, and you have to do that always.
Yeah, and like Nikolay had shown that slide initially, differentiation between upper motor and lower motor, because both of them will present with weakness initially. So you can't differentiate unless you do the rest of them, whether it's spastic or hypo. So all the more reason to look for, if it's intracranial, look for lower cranial nerve involvement also with that.
Yes, exactly. So the full neurological examination, very important.
Shazad, you want to?
Sorry, I want to add a question here. Where do we use jaw jerk? What does jaw jerk what things that help us in differentiating when we use jaw jerk? Where do we use it?
So jaw jerk is a symptom that can help you with the brainstem lesions. So this is something that you can examine if you are thinking of a brainstem lesion. Do I understand your question properly?
Yeah, it's fine. It's okay.
Do you want to specify a bit more about that, or?
No. I'm just saying, when many times when you've got a brain lesion and cervical spine, you want to differentiate, you can use jaw jerk as well at that time.
Yeah, so the jaw jerk is obviously trigeminal. It will show the trigeminal, the problem with the trigeminal nerve and the nuclei of the trigeminal nerve, which is brainstem mainly, and the sometimes upper segments of the cervical spine.
Yeah, so it's easy.
If I can add also, it's like a jaw jerk is a masseter. So differentiate between a trigem and a C-spine. So different between above the foramen magnum versus cervical spine.
Yeah,
if it's present.
So that's another tool that we have. Anyway, carry on, guys. Nikolay, you've got 5-7 slides to show. Have you got 5-7 more slides to show? We have time. If you want, we can show them.
So I can show you. There is some cases which I have here, but
okay, no, then it's instead let's finish the questions first, then we can do the MCQs that we have.
Okay.
Okay.
So any other questions then?
Yes. Shazad, go ahead, please.
Shazad, you need to be unmuted.
So,
sorry.
Yes.
Go on.
Can you hear me now?
Yes.
So Nikolay, the next question is, how much do you rely on surface landmarks for localization of spinal lesions? So for example, the manubrium sternum as a landmark for D4, D5 space, or the anterior superior iliac spines for the L4, 5 space?
Yeah, well, of course, we have these superficial landmarks that will help us and will guide us with diagnosing, with localizing different levels. This is something that we have to know, but obviously with the modern practice, we cannot rely on that in 100% of the cases. For example, I can give you a good example of that. We know that the biiliac line will lie roughly. In some books, you can find it lying at level of L4 vertebral. You can find it lying at level L4, L5. But if you go and operate L4, L5 disc herniation, you don't go and do only superficial landmarks. You don't go and do biiliac line and then go dive in there and operate your disc, because you still have a high chance that you can operate the wrong level. So the superficial landmarks are important. If you get, for example, superficial landmark like L4, L5 biiliac line, if we go there, you will position your X-ray appropriately from the very beginning, and you will do less X-rays, but you will not rely only on the superficial landmark. You will still do your X-ray. So that's my comment on that. The superficial landmarks are important, but obviously this is part of the whole examination and part of the whole picture, and you cannot rely only on one or the other symptoms. You have to know as many symptoms as you can. You have to have as many tools as possible in your toolbox, and then only you will be versatile to use the appropriate examination in appropriate situation. And if you use many, the right answer will be where everything is crossing.
So Nikolay, I'll add a question also, and then we can clarify. So for the youngsters, what is sciatica? Because I see this all the time. You know, if you say sciatica, they'll say L5S1 disc herniation or 4. So you want to clarify on that, please?
Okay, right. So many of my patients are coming and they say, I have sciatica. So I think sciatica now is becoming a lay term. And patients, at least when my patients come and they say I have sciatica, they mean that I have leg pain of some sort. So this is my understanding, and that's how I accept it now. A sciatica is so historically sciatica is obviously related to a sciatic nerve problem. However, now when I examine my patients, that's what they mean. They mean problem with the leg. They have leg pain, and I tend not to use that term sciatica because I feel at least it's very inaccurate. So when I talk to professionals, I will rarely use sciatica. I will normally try to localize and to specify a specific dermatome. I will talk about radicular symptoms in a specific dermatome or myotome, but I will tend not to talk about sciatica because now I think this is something that became a lay term, and I hear mostly my patients using it.
So you know, I see a lot of doctors also presenting or complaining, you know, we have a sciatica. So just for the audience, sciatic nerve is basically L4 to S3 technically, right? L4, 5, S1, 2, 3. So like Nikolay mentioned, it could be L4 radiculopathy, could be L5, could be S1, could be S2. So all of these are sciatica technically. So it's better not to use this term and explain to them this is L5 pain or L4 pain or S1 radiculopathy. Shehzad, you want to ask the next question, please?
Yes, but before I do that, I'd just like to emphasize what Nikolay mentioned earlier on, that to be able to localize a level in the spine does not mean that you rely on that only. It has to be supplemented by proper radiological investigations, and if it's required, with electrophysiology. And under no circumstances should you be making decisions based entirely on clinical examinations without taking into consideration the radiology. So the next question is, we have quite a few questions asking about the management of a spinal injury. I don't think that's the curriculum for today's lecture. So Nikolay, if you can answer this question, what is the pathophysiology for loss of bulbocavernous reflex in complete versus incomplete injury? The pathophysiology for loss of bulbocavernous reflex in complete versus incomplete injury.
Right, okay. So you have to go back to that diagram that I was showing you, and you have to remember that the bowel and bladder function is following the same rules as the central versus peripheral type of weakness. So basically, if you have preserved the second neurons for your bowel and bladder function, which are localized in your conus, then obviously you will have the reflexes preserved. And that is the pathophysiology.
Okay, so I guess like how Dr. Shehzad mentioned, I think some of the questions are likely not related to this localization talk. So maybe we'll try to skip some of them, but keep on asking you the related anatomical questions. So how to differentiate between decorticate and decerebrate rigidity?
How to differentiate between decorticate and decerebrate?
Cerebrate, yes.
Right. So basically you go and examine your patient, you provoke the patient, and you see the specific postures for the decorticate and the specific posture for the decerebrate. So for the these are the two main. This is clinical diagnosis mainly, and the anatomic. Yes.
Go ahead, finish.
Yeah. So this is how you discriminate. You go and examine your patient, and there is a very distinctive posture for the decorticate, and there is a very distinctive posture for the decerebrate.
I think just to elaborate on that, what Dr. Nikolay means is that I have always had mnemonics for everything. So it's sometimes you forget what is decorticate, what is decerebrate. So if your decerebrate is E, CE, right? Cerebrate. So this is how I remember. So decerebrate is extensor, right? Which is worse than decorticate. Decorticate is flexor response, and decerebrate is extensor response.
Okay.
And after this, the last one is flaccid, which is basically none. So, okay. So next one, Azad, do you have any?
Sure. So the next question is, again, we're getting a lot of questions about cortical localization. And Nikolay, it's up to you if you would like to answer this. So, but this question is how to differentiate between any degenerative disorders of the brain with any spinal lesions. So you can say a girl of 6 years of age presents with ataxia, frequent falls with exaggerated reflexes. How would you differentiate whether it is a spinal lesion or any brain disorder?
Right. So obviously, you have to follow the same pattern that you follow with every patient. It is going to be difficult for me to precisely answer that question because maybe I'm lacking a lot of information about that. But if I understood properly, the neurodegenerative diseases and was that the question? Neurodegenerative disease.
No, the question is how do you differentiate between, how do you localize the disease, whether it's from the brain or from the spine in a patient with ataxia, frequent falls, and exaggerated reflexes?
Right. So again, yeah. So basically, I'm missing a lot of information. So you have to go and follow the same pattern that you follow when you examine all of your patients. You have to see what is the history, how long is the falls, where are the falls. You have to go and see the full clinical examination of the patient. I will probably not answer the question appropriately because I'm missing. This is a patient this is a clinical scenario, and I have to examine the patient. I have to see the full history, and then probably I will be possible to give you more about that. So it's I don't know if you can.
Yes, I think that's a very important point that you raised, Nikolay. Whenever you feel that you do not have enough information about a patient, it probably means that you need to spend more time in taking the history and examination. And in this particular case that we've been presented, I think a more detailed examination will reveal a lot more information that can help you localize.
Yeah, this is basically, when you have one or two symptoms, sometimes you can create only a very long differential diagnosis, but it's going to be difficult for you to specify.
Okay, I'd again request the participants to please fill the questionnaire that we've requested you to fill so that your certificate could be given to you. We are putting the link back on. And the reason is that we just have 5 more minutes of discussion before we show the results and then discuss those multiple choice questions with Nikolay. Is there any more question, Asif? That
I see one more question here. Nikolay, can you please differentiate between central and peripheral bowel in bladder function?
So central and peripheral bowel and bladder function. So the central type is, we said that the first neuron of your bowel and bladder function, the voluntary bowel and bladder function, is located in your cortex. And then it travels all the way down to meet the second neuron for your bowel and bladder function, which is in the conus medullaris. So everything that is impairing the first neuron will give you central type of bowel and bladder function. So what is central type? This is a patient that goes into retention. So this will be retention of urine, and this will be retention of feces. So what happens with a patient that will have retention of feces? You see a patient, most of these patients now will be catheterized. If you go and see this patient, most of them will be catheterized already. But if you leave the patient non-catheterized, you see that the bladder will fill up. Sometimes in the old books, they compare this with a look like a pregnancy. So you see the bladder above the pubis, above the symphysis, and after a period of time when the bladder will reach a critical capacity, will discharge itself, because there is a inbuilt reflex in the bladder where after a specific critical volume is reached, the bladder obviously has choice or to burst or to discharge. And you see these patients, if they left uncatheterized, they will discharge urine on a certain period of time, and then the bladder will refill again. This is the central type of bladder disturbance. And the bowel disturbance central type is just retention of feces. And these patients, they, if left like that, many of them will go to ileus and die, and you have to go and manually disobstruct them to prevent this happening. While with the peripheral type of bladder and bowel disturbance, you have incontinence. You have constant dripping of urine that so the bladder will discharge without stacking up any levels, any volume. And the same thing is happening with the bowels. You have discharge of you have a patient that has diarrhea, and it is constantly leaking. These are the two. And if you go and examine the sphincters, you see, for example, that the anal sphincter has no tonus. The sphincter is opened, and everything is leaking.
Good. I think we're getting towards the end of it. Salman, you wanted to review the feedback.
Yeah,
I think
we can do it now. We're just going to get it on. It will take 1 second. So for the moment of truth, Nikolay.
Okay.
So we have 75 responses of the 150 we had initially, and now we are up to 124. And so let's look down. Can you see the responses? Let's have a look at the results. Oh, let's look at the questions. Sorry, let's look at the questions first, and then we can discuss. Shahzad, do you want to take us through the questions?
Sure. So the first question is, a middle-aged male with the history of progressive lower limb weakness and mixed symptoms of upper and lower motor neuron features. Most likely lesion is at which level? The options are upper dorsal spine, cervical spine, conus medullaris, and cauda equina. Okay,
so let's go on to the next question.
Elderly female with headache and gradual onset of generalized weakness. On examination, reflexes are brisk. Hoffman and jaw jerk is positive. Localize the lesion. Options are cerebellum, mid-pontine, upper cervical spine, lower cervical spine. Should we go through the answers right away, or should we go over the questions first?
We can go over the question, and when we're going to see the answers shortly.
Okay. The third question is, middle-aged male patient with lower back pain and right lower limb radiculopathy, diminished ankle and knee jerk, and asymmetric numbness and atrophy. Localize the lesion. The options are upper lumbar spine, conus medullaris, cauda equina, and lower dorsal.
Okay, let's go back to let's get the responses, see where we are with the responses. So let's go up. So if we see here that we have, let's go up. So I'm just looking at consultants and residents. So as we can see, the majority of the people who are attending our residents, that's our focus. Come down. It's okay. Let's move on. And the interest. Okay, go down. Yeah. So you can see majority of the people in this group who are attending have their interest is spine. Let's go down. Let's get the questions and see what the answers are. What we did. So Shazad, take it away, please.
Okay, so the answer to the first question, I'll repeat the question. A middle-aged male with a history of progressive lower limb weakness and mixed symptoms of upper and lower motor neuron features, most likely lesion at which level? Most of the respondents answered conus medullaris. And I think the correct answer is also conus medullaris. Is that right?
Yeah, Nikolay, you won. One done. Okay.
The second question, elderly female with headache and gradual onset of generalized weakness. On examination, reflexes are brisk. Hoffman and jaw jerk is positive. Localize the lesion. The options were cerebellum, mid-pons, upper cervical spine, lower cervical spine. Most people answered upper cervical spine. No, actually, most people answered mid-pontine, which is also the correct answer. Am I right?
Yeah.
So well done, Nikolay.
Please explain why other people are wrong. Please explain.
So there was a discussion on this as well. Whenever you're confused with an upper cervical spine lesion or a brainstem lesion, a useful test is a jaw jerk. Now, the jaw jerk signifies that the lesion is at the level of the trigeminal nerve nuclei, which is in the pons and the medulla oblongata. So if you have a positive jaw jerk, then the lesion is higher than the upper cervical spine, is actually extending into the middle brainstem, so mid-pontine lesions. And the fact that this lady has a jaw jerk present means that the lesion is higher than the cervical spine, extending into the mid-pons. Now, this is extremely important for localizing lesions, but in this day and age, whenever you get a cervical spine MRI, you will also get images of the brainstem as well. So this, but this is a useful exercise to keep practicing whenever you're seeing patients.
Okay, good. Next.
Next question was, middle-aged male patient with lower back pain and right lower limb radiculopathy, diminished ankle and knee jerk, and asymmetric numbness and atrophy. Localize the lesion. The options were upper lumbar spine, conus medullaris, cauda equina, and lower dorsal spine. And most people responded cauda equina, which is so that seems to be the right answer. Cauda equina.
Yeah.
So Nikolay, you got 3 out of 3.
What is it? Sorry.
3 out of 3.
3.
Good job. 100%.
Okay.
So let's look at the feedback that people gave on your talk. Let's come down. So 80% felt that quality of evidence was good. Very good. Let's keep going. In fact, 85%. Content, again, 85% felt the content was good or excellent. Rate of overall presentation, you can see again, 80 plus, excellent and good. Keep going. We have already done that. Keep going. Down.
Again.
Would you like to hear the presenter again? So 98% feel they would like to hear you again, man. Good for you.
That's good. It's good that you do that feedback. It's good. I like it.
No, we just make it for yourself to make you happy.
That means, Nikolay, you can't get away. You gotta keep on speaking.
Anyway, so even if you made it, I'm happy. Thank you.
Okay, guys. I think we're going to wrap up here. It was excellent. Any questions from anybody in the audience, or Asif, Shazad, Nikolay? You have any?
So I'd like to make a comment.
Yeah,
I'd like to make a comment because I even though we're doing it for the juniors and the residents teaching, I really think I've also learned a lot during this revision of. So I think it's more important for the seniors to brush up their anatomy and all that. This is what I feel.
Okay, we'll put that comment on our seniors group. Don't worry.
I think to an extent he's right, because with our busy work and with we just go away from the basics, and sometimes we have to go back and refresh our memories about this.
I think I did learn a lot. I must say that there are things that that I just take for granted, but revising all this with you was brilliant. I'm grateful. I think it was a very good talk. This talk will be available via YouTube tomorrow. All the previous 10 talks that we have done up till now are on the YouTube channel, and you can access that. The details of it are on the Facebook page that we have. This is the talk that we have day after tomorrow with Vlad Beniz. He's the famous skull-based surgeon, and he's going to be talking about arteriovenous malformations. We have Professor Khalid Mahmood and Azam as the co-moderators there on this, and it's going to be again at noontime. Everybody most welcome, and I must say that there are things that we learn when we go through these talks, and we have time, so we must use this time that we have.
If I can add one more thing, I haven't been regularly attending, but the couple I've attended this one, I really think that the credit really goes to Salman and his team and all that, because this is not just because Corona is here and we are all hiding and trying to do that, but this should be a lifelong learning thing. And I really think if we can do this like a monthly thing, bi-weekly, and of course, Salman being the president of PSN, he thought of this idea, and I think this is giving us, so all the youngsters, they need to tell their other friends, colleagues, and all of us also, because the next talk about AVM looks like very interesting, right? So this is a way of learning as well as teaching also. This is what I feel. And this is now maybe the world has already changed, and this is how the teaching is going to be in future. And we should try to rely on this more and more, web-based.
Okay, Shahzad, few comments, and then we close.
Yes, I'd like to resonate Asif's comment. I mean, the fact that this is the 10th lecture and the audience seems to be growing every week is a testament of how well this is being taken. And I would like to thank Salman Sharif and the society for organizing this. I do feel we need to have a sort of a curriculum, a year-long curriculum, and so we can cover all the topics over the next year, because Corona or not, this is an extremely useful exercise. We should not be stopped. I would like to mention this, that it's also very nice that despite the lockdown, this gives an opportunity for us to once again hang around with friends despite the lockdown. So thank you very much for that as well.
Okay, thank you all. Nikolay, any words? We are grateful for a brilliant presentation, and
as always, pleasure to be with you personally or virtually, and thank you so much for the opportunity. As as it was already